It's thinking, and there it is. Okay, should be good
Perfect.
to go.
Easy enough. Thank you.
No problem. Let me sign you back to being the host.
Okay.
Okay, and I will sign off.
All right. Sounds good. Thank you again.
No problem.
Bye. Bye.
Hi, Gunnar.
Hello. How are you doing?
Okay.
Good.
This looks different than it did the other day.
How so?
Well, right now, my screen has an array of participants' names spread out across it with my video in the middle.
Okay, you probably just need to change your view in the top right to something other than gallery. And if you start sharing your screen, it should so snap to normal looking as well.
Okay. Um,
That looks good.
you got the right one?
Yep.
All right. That's always good. And when we want to do the poll, you'll just post it in the chat.
It just pops up on the screen. I can show you right now, actually.
Oh, okay.
So do you just want to do the one that you mentioned, or do you want to do the others that we normally do?
I think just the one we mentioned.
Okay, that's what that one will look like.
Okay, great.
And then once we are done with it, I can show the results. So,
Okay, great. Okay, great. Wonderful. Okay. Now it's still on my screen, should it be?
um, mm, no.
It is still on my screen. I have a red X I can click. And
Okay, yeah, maybe because you're a co-host instead of a panelist or whatever you used to be in the webinar format, you'll just have to close it on your end too.
okay. All right. Just want to make sure that everything's working here. Ooh. There are some different options here for me today. There's a CC and there's a video camera
Yeah,
and
those are within PowerPoint itself, not Zoom. It's interesting.
and a magnifying glass. Huh. I don't remember ever seeing them before.
Yeah, I'm not sure. But yeah, I know they're PowerPoint specific, not Zoom.
Yeah, because I just turned on the closed captioning and it kind of changed things. Did it for you too?
Yeah, so it'll bump up your presentation window and then it would put captions underneath, I presume.
Huh. Interesting. Okay. Well, I don't think we're going to do that. We're going to use our Zoom captioning.
Yeah.
Okay. Well, for those of you who have signed on early, as you can tell, we're just getting our technology all worked out for today's webinar. We'll be starting at the top of the hour, which is in about 25 minutes. Uh-oh. Did something happen?
Yeah, looks like you hold up the PowerPoint window.
Huh.
That's interesting.
I don't know what I did. I have
I don't know
no
what you did
idea.
either.
Hmm. Can you hear me still?
Yeah, I can see and hear you. It just looks like your screen share ended on my end.
Hmm. Are we back where we should be?
Yeah, that looks okay to me. That was strange.
Yeah. Well, we got to be kept on our toes. All right.
And Mandy is here, and I'm keeping an eye out for Terry.
Hi, Mandy.
Hello.
How are you today?
I'm good. Got everything ready on my end.
Good. Do you have your video ready to turn on?
I will. I don't have it right this minute, but I will.
Okay. All right. For those of you who have signed in early, I just want to welcome you and let you know you're in the right place for today's webinar, Introduction to Evidence-Based Hearing Screening Practices for Children Birth through the School Age. Um, we'll be starting at the top of the hour in about 15 minutes here. So you can settle in, get your volume adjusted to your liking. Um, just so that you all know, I'll be saying this multiple times, but today's webinar, like all of our webinars, is going to be recorded and then posted on our website, which is kidshearing.org. So if anything disrupts your full attention to today's webinar, or if you think of anybody who would benefit from today's webinar who is not participating, just know that you can access this webinar again through our website at kidshearing.org in the next couple of days. And then it'll be up there for ever. So anyway, we'll be starting at the top of the hour in about 15 minutes. Thanks everybody for being here um, in advance. Terry, it looks like you're on. Are you able to give a quick?
I am. Thank you.
Okay, good deal. And we've got Mandy as well. Mandy, are you able to do your test with us?
Yes, I am here. Can you see me and hear me?
Yeah, there you go. All
Good.
right.
Good to see you, Mandy. Thank you.
Good to see you too.
Yeah. So everybody, we'll be starting at the top of the hour. Um, so we will be checking in periodically as people sign in, letting them know that they are also in the right place and to get their volume and what have you adjusted to their liking. You'll also notice there's a captioning option on your screen there. So if that would help you in following along for today, feel free to initiate that. Um, so there we go. We'll be checking in again in a few minutes. Hey, for those of you who have just signed on, you're in the right place for today's webinar, Introduction to Evidence-Based Hearing Screening Practices for Children, Birth through School Age. We're going to be starting at the top of the hour, about 7 minutes from now. We had well over 1,200 people register for today's webinar, which we were delighted to see. So we have people signing in at a fairly rapid pace right now. Today's webinar, like all of our webinars, is being recorded. So if anything disrupts your full attention to today's webinar, or if you think of anybody who might benefit from it that aren't in attendance today, know that this can be accessed again on our website, kidshearing.org, in the next couple of days as a recorded webinar. And you'll find this and other recordings there, along with many other resources to support evidence-based hearing screening practices across a broad age spectrum. And again, that is kidshearing.org. We always like to say, if you don't remember anything else from today's webinar, remember our website, because all of the information that we're sharing is accessible there in various forms. So be aware of that. So we'll be starting in about 5 minutes at the top of the hour. For those of you who are just signing on, you're in the right place for today's webinar, Introduction to Evidence-Based Hearing Screening Practices for Children, Birth through school age. We have a lot of people registered for today's webinar, over 1,200 in fact, and people are signing in at a fairly rapid pace right now. So we're going to sit tight for a minute while people are making their transitions over from whatever they've been doing this morning or the first part of today to being able to join us here for this conversation. We'll be starting in just a few minutes here. As some of you who have been on for a few minutes already have already heard, today's webinar, like all of our webinars, is being recorded and will then subsequently be posted on kidshearing.org, which is our website. That's kidshearing.org. So if anything disrupts your full attention during our webinar today, or if you think of anybody who would benefit from the information that is being provided today, your colleagues, decision makers, even parents, feel free to direct them to our website and to view this as well as to explore the many different resources we have there that are all there for you to freely use to ensure best practices related to the identification of children who are deaf or hard of hearing, who have any degree of hearing loss, so that children can succeed in school and socially and in all aspects of their lives. We're going to just sit tight for another 2 minutes, I think, because boy, people are just signing on really rapidly right now, and we just don't want to overlook that transition that people are going through as they close their office doors or adjust their attentions to what we're going to be doing today. You'll notice that there's a captioning option on your screen. If that would support your understanding of the information that we'll be conveying today, you can activate that and adjust it to your liking. We will be opening up the chat option once we've completed our remarks for today. We're not going to be doing an interactive chat throughout our presentation, but we're going to first deliver some information and then open up to questions. So that's how we're going to use the chat today. Let's give it one more minute and then we'll get started here. For those of you who have just signed on, we're just sitting tight for just a minute while we allow people to sign on, just like you have. You're in the right place for today's webinar, Introduction to Evidence-Based Hearing Screening Practices for Children Birth through the School Age. Well, I think we ought to get started. What do you say, Mandy and Terry?
Let's go. Yeah, thank you.
I agree.
All right. Well, welcome everybody. You are in the right place for today's webinar, Introduction to Evidence-Based Hearing Screening Practices for Children Birth through School Age. My name is Will Eiserman, and I am the Affiliate Associate Director at the National Center for Hearing Assessment and Management, also known as NCHAM. Now, NCHAM is housed within the Institute for Disability Research, Policy and Practice at Utah State University, which is federally funded as a university center for excellence in developmental disabilities with a critical nationwide focus. since the early 2000s, 2001, in fact, I also served as the director of the Early Childhood Hearing Outreach Initiative, known as the ECHO Initiative. And for 20 some years after that, the ECHO Initiative has served as the National Resource Center on Early Hearing Detection and Intervention, with a focus on supporting early Head Start and Head Start program staff, and other early care and education providers in implementing evidence-based hearing screening and follow-up practices. And we're delighted to continue to make our resources, other learning opportunities like this one, available to staff from Head Start programs, as well as early intervention programs, other early care and education settings that cut across all of the different age groups for whom we need to be monitoring the hearing status. So we are really delighted to have so many of you with us here today. And by way of reminder, today's webinar is being recorded and it'll be posted then in the next couple of days on our website, which is kidshearing.org. So if anything disrupts your full attention today, or if you think of people that could benefit from the information that we're talking about, whether that's your colleagues, decision makers, even parents, healthcare providers, anybody who is involved in monitoring and supporting the development of children, feel free to direct them over to our website to see this webinar, as well as to explore the many other resources that we have there and that we'll be pointing out as we present today. Now, I'm joined today by Dr. Terry Faust, who is a good friend and colleague of many years. Dr. Faust is a pediatric audiologist and speech language pathologist who has served as a consultant and trainer and advisor to us at the ECHO Initiative since our very beginning. So, Terry, thanks for being with us again.
Yeah, thank you so much, William. Boy, just as like William said, he and I, along with many other ECHO team staff and collaborators like you, we've provided training in nearly every state in person, and then virtually, I'm sure, with every state and beyond. We have worked with thousands of staff from many different kinds of programs: Head Start, Early Head Start, Alaskan, American Indian, Alaskan Native Migrant Head Start programs, and many other early care and education programs in schools over the years. We also have with us Mandy J, who is presenting with us today. She has a master's in public education and is a program coordinator for the National Center for Hearing Assessment and Management.
Terry, let me just correct that. She has a master's in public health.
Public health. Yes, that's right, Mandy. I'm sorry about that.
You knew that. You knew that. That was just a word.
And I think one of the most important things she brings is her experience as the parent of two children who are deaf or hard of hearing. And we're really thankful to have her with us today because she brings multiple perspectives to our work.
Thank you, Terry and Will. I'm thrilled to be here. Thanks for having me. We are very excited to have over 1,200 people registered for this webinar. It is always encouraging to have the huge amount of interest in evidence-based hearing screening programs so that we can help children who have hearing-related needs be identified and served. As a parent of children who are deaf, this is extremely important to me and very personal to me, and I appreciate all of you being here to learn more about how to serve these children and their families.
So that's who we are. Gunnar, could you put the poll up for a quick second here? We'd like to know at least a little bit about who you all are in terms of the primary work setting or role that you are serving in, so that we have a little bit of a sense of the diversity of who you all are. And I'm seeing quite a lot of diversity in terms of people from Head Start, Part C early intervention, Part B 619 home visiting, a couple of healthcare, several healthcare providers, a number of school nurses, and then some others, which of course that always makes us wonder, who are those others? I wish we had an easy way to fill that in. Um, but that, thank you for giving us that insight about the diversity of folks that we have here today. Okay, Gunnar, that's great. Thank you for giving us that chance to see who some of you all are. And thank you, Mandy and Terry, for your introductions. You know, the work of the Echo Initiative, you know what I'm going to do? I'm going to turn off my video so that you guys can all focus on the more important images rather than my mug. Um, so the work of the Echo Initiative is based on the recognition that every day there are children who are deaf or hard of hearing, meaning having some degree of hearing loss, that are being served in various early childhood or school or healthcare settings, often without their hearing related needs being known at all. Hearing loss is often referred to as an invisible condition. So the question that leaves us with is, how can we
Hey,
reliably?
William, sorry to interrupt. We can see your background presentation again.
Oh, all right. Hold on a minute. I have no idea what happened. So now I need to share again, I'm suspecting.
Yes.
Okay. Sorry, everybody. A little technical glitch here. It's been a while since we've had technical glitches. Uh, I'm sorry. Hold on one more moment. There we go. And another click here. Okay.
That looks
Am
okay to me.
That looks great.
Okay, thank you. So what I was saying was that, you know, hearing loss is often called the invisible condition. But how can we reliably identify which children have normal hearing and which do not?
Yeah, really, William, the short answer to that question is that early care and education providers can be trained to conduct evidence-based hearing screening, just like you see in these photos here on your screen. The ultimate outcome of a hearing screening program is that we can identify children who are deaf or hard of hearing who have not been identified previously. Now, the procedure you see on the left-hand side of your screen, that's called otoacoustic emissions, or OAE, which we'll refer to it going forward, OAE hearing screening. And that's the recommended method for children birth to 3 years of age, and it's increasingly recommended for children 3 to 5 years of age as well. Now, on the right, you'll see the procedure pure tone audiometry hearing screening. And that's been historically the most commonly used screening method for children 3 years of age and older, which you'll still see in many early care and education settings and providers using. And so we're going to talk about both of these methods today.
So let me give you a quick overview of what we're going to cover today so that you have an advanced organizer. While this presentation is not considered a training per se, our goal is to provide an overview of what we consider the big picture of what is involved in implementing evidence-based hearing screening for children across the age spectrum, birth through school age. And we're going to start by giving you an overview of the auditory system or the hearing system, which will help lay a foundation for understanding how the hearing screening methods we'll be talking about today actually work. We're going to talk about why we screen for hearing loss and what even makes it possible for us to be seriously engaged in systematic screening for hearing loss. We'll then talk about the two methods that Terry just mentioned, otoacoustic emissions and pure tone audiometry, starting with an overview of the OAE hearing screening process, followed by an overview of the pure tone audiometry screening process. Next, we'll address the important question, so what do we do next when a child doesn't pass a screening? We'll summarize those follow-up steps that are undertaken when a child doesn't pass a hearing screening on one or both ears. And then we're going to wrap up by showing you how to access a wide array of resources that we have available on kidshearing.org, our website, that are there to support the process of developing, maintaining, and even monitoring the quality of your hearing screening program. And then, of course, we'll open up for questions that you might have that we can be helpful in addressing. So that's where we're headed. And you can follow along our progression through these topics by referring to the left side of your screen. And since this is a recorded webinar, if you're actually watching this as a recording, you can jump forward or move around by just looking at that left column to see what areas you want to jump to. So know that that's available for you. Mandy, why don't you talk to us a little bit here about what evidence-based hearing screening practices are?
Yes, you're going to hear us emphasize evidence-based practice a lot throughout this webinar because it's very important that we focus on that evidence-based practice. So there are three key components to that. The first one is that we want to use recommended screening methods that match the child's age and developmental level. Very important that we adapt for that for the child. Second, we want to implement follow-up in the recommended sequence and within the appropriate time frame when a child does not pass in one or both ears. Again, we want to make sure we're looking at the follow-up there for what the next steps are. Third, we want to document all screening outcomes, gather follow-up diagnostic information, and ensure access to intervention services. Those three elements define evidence-based practice. While we understand that people focus on what the recommended methods are when aiming to implement evidence-based practice, and clearly we want to use the appropriate method because that is essential, but screening is only as valuable as our follow-up. So when you are considering your practices, we want you to also have the appropriate methods for follow-up and reporting on this. How many children have you screened? What are their pass and refer rates? How many were referred for audiologic evaluation? How many completed the evaluation? How many were identified with permanent hearing loss? What supports are these children and their families receiving? We want you to look at the full picture, not just the initial screen, so that the effort is meaningful and does what it's supposed to do.
Well put, Mandy. So let's set the stage with a quick review of the auditory or hearing system. Terry, you're our pediatric audiologist, so why don't you walk us through this?
Yeah, thank you, William. So let's take a good look here at the ear that you see on your screen. There are three main parts to the auditory system.
There are three main parts to the auditory system:
Sorry, Terry.
the outer ear, the middle ear, and the inner ear or cochlea. As this mother's voice reaches her child's ear, The incoming sound causes the eardrum to vibrate, which then moves three small bones in the middle ear. This movement stimulates thousands of tiny sensitive hair cells in the inner ear. From the inner ear, the sound signal is carried along special nerves to the hearing centers of the brain, and the child experiences the sensation we call sound.
It's open.
So that's a little excerpt from one of our trainings on OAE screening. So sorry, Terry, I forgot that I stuck that little excerpt in there, but you can continue here.
No, that was perfect. So yeah, as you take a look here, just like was explained, we have the outer ear, the middle ear, and the inner ear. And so as the sound travels through, you can see where those little green dots on that inner ear are. That's what's stimulated, and the sound goes up through the auditory nerve, and we perceive sound. So while this is how the auditory system typically functions, there can be some exceptions. We can have temporary issues like a wax blockage that you can see there. We can have fluid in the middle ear that's commonly caused by ear infections that we can discover and that we get addressed during the hearing screening process. But the primary target condition of the hearing screen is the functioning of that inner ear or cochlea. It's that snail-shaped portion of the ear. Now, in some instances, the sound will travel through the outer and the middle ear, but when it reaches the cochlea, the signal is not transmitted to the brain, and that results in what we call a sensory neural hearing loss. This condition is usually permanent, and it, again, like I said, it's the primary target condition for which we are screening in all of our mass screening efforts. Now, we need to screen throughout childhood because hearing loss can occur at any time. It can occur as the result of illness, physical trauma, or environmental or genetic factors. And this hearing loss that happens late like this is referred to as late onset hearing loss. And that just means that it's acquired after the newborn period.
Yeah, so it's commonly understood that language development is at the heart of cognitive and social emotional development and academic achievement. I mean, that drives most of the practices that we see in all educational settings from early on all the way across the years in school. Think about how much emphasis is placed on language development in early childhood, counting the words children produce, noting the first word a child says. Our emphasis on language begins almost immediately, and it remains in place across all of those years. It's also important to note that hearing health is at the heart of typical language development, and that if we're going to be conscientious about promoting language as a part of our commitment to educational achievement, we should probably be equally conscientious about monitoring the status of hearing throughout childhood. If hearing is compromised to any degree, then language development will ultimately be compromised as well. And we don't want to wait for a language delay or other observable concerns to arise, only then to discover that the child has developed a hearing loss. But that actually can, in fact, happen. And that can happen because permanent hearing loss is often referred to as the invisible disability. Even though hearing loss, permanent hearing loss, you might not know this, is the most common birth condition in the United States. It affects 3 in 1,000 at birth, and then the prevalence actually doubles by the time children enter school to about 6 in 1,000. And then after that, it steeply increases to about 50 in 1,000 during the school age years. So we always want to point out that while hearing loss may be invisible, these children actually need to be seen. We need to identify them so that they can thrive. And those statistics are really important for all of us to be able to use as we are garnering support for our screening efforts and our follow-up efforts, whether we're needing that support from our colleagues, from teachers, from decision makers, or from parents, or even healthcare providers to whom children who don't pass are referred. Why is hearing loss called or referred to as an invisible condition? Well, it's for a variety of reasons, one of which is that hearing loss can be of any degree, just like a vision impairment can be. It can be subtle, it can be mild or moderate. It's not just all, either you hear or you don't. It's not like either you see or you're blind. It's a broad continuum. And even slight mild hearing losses can affect a child's learning. Children are also able to kind of trick us, not intentionally, but they'll follow the behaviors of their peers that lead us to believe that they're actually hearing everything clearly when maybe they're not. They're just learning to accommodate. Sometimes when hearing loss is not identified, it can also look like other conditions, like a possible learning disability, or a behavioral concern, or a mental health need, or being on the autism spectrum. So we want to screen for hearing for lots of reasons because we don't want children to be misdiagnosed and we don't want them to be underdiagnosed either. And in the ECHO initiative, early on, when we were working primarily with children in the birth to three arena in Head Start programs, we found that when children were actually identified ultimately with a permanent hearing loss, many of them were already being served by early intervention programs for speech and language delays, and their hearing loss had not been identified. So, the effectiveness of speech therapy in the absence of an identified hearing loss, if that's in fact the case, is going to be minimal. So we want to make sure that we never make assumptions that hearing has been evaluated and ruled out when in fact we know from these statistics that the increase in the prevalence of hearing loss does nothing but go up across all of the school years.
So, William, yeah, this exactly. And that actually is the perfect place for us to take a minute right now to make sure that we're all on the same page about what a hearing screening actually is. Um, think of screening as kind of a sorting process. It's a sorting process that helps us separate the children who are at risk of having a condition from those that are far less likely to have the condition. Those in that first higher risk group are then followed up with additional steps implemented by pediatric audiologists and healthcare providers to continue to refine that sorting process until we have definitively identified the small group of children with a hearing loss. And really, just to be blunt, we screen because we simply can't provide a full comprehensive audiological evaluation on each and every child.
Yeah, if we could do that, we would, right? But we can't. So we do screening instead. Screening, when it's followed by appropriate audiological assessment and intervention, can dramatically improve the outcomes and options for children who are deaf or hard of hearing. And again, keep in mind that hearing, like vision, can be impaired along a broad continuum of severity. And even mild hearing loss can and have very real consequences on a child's learning and socialization. But when hearing loss is identified early, we can make sure a child has access to language and information, and that this is the case across the age spectrum.
With improvements in technology, um, there's been dramatic improvement in our ability to identify hearing loss in children, starting with newborn hearing screening on the day they were born. As a result of these improvements in hearing loss identification, children who are deaf or hard of hearing are thriving in ways that used to be rare. William, let's take a look at several examples of children with severe to profound hearing loss who have had the benefits of early identification and quality intervention services.
Yeah,
These
great
children
idea.
are learning, thriving, and communicating.
They are thriving. Now, these two girls both wear hearing aids. They have um, severe hearing loss. And let's just listen to their conversation as they play with their dolls here.
We're having a party over here. You're gonna miss it. Okay. Are you guys talking? Meow, meow. I'm skating. Whee! No, Daisy. Look, this is the water. She's skating on the water. Whee! Whee!
Hey, William, this is Daniel. I'm sorry to interrupt, but I jumped in for Gunner temporarily. Your PowerPoint window's covering up the video so the audience can't see the video.
That happened again. How about
Okay, now,
There you go.
yeah, now go ahead and play the video again.
I'm so sorry.
Oh, tattoo.
Good now.
I will touch you, and I will touch you, and I will touch you, and I will touch you.
Yeah, so that's one example. Now, in this next example, these boys' parents selected that they learn sign language as they are deaf. And let's look at their language abilities. And let's give you one more example. These two boys have cochlear implants. They are deaf, and this is not how deaf speech used to sound. Um, so take a look at how they are communicating.
Okay. Hi, my name is Gibson. People are special in different ways. One of the things that makes me feel special is that I'm deaf. I'm deaf too, and deaf means that your ears can't hear. AJ and I have special things to show you. They're called cochlear implants. They help us hear. Cochlear implant is a big word, so I call them CI.
Oh, yeah. So Mandy, your kids are among those who are thriving. You have your own story. So take a minute and tell us about the role that hearing screening played in your life.
Yes, thanks, Will. I am the parent of three girls, and the oldest two are deaf. They are now 25 and 21, so they are no longer children. But they both passed their newborn hearing screening. Um, it's very important to me in my work to say that newborn hearing screening is critical and important, and we should do that. But my kiddos fit what we're talking about today, that it was later when they had late onset, or perhaps it was such a mild loss at birth that it wasn't captured. We don't know the answer to that. But my oldest was almost 3 when I was noticing her speech was slightly delayed to my nephew, who was the exact same age as her. And I know you're not supposed to compare, but I did compare, and that helped make a difference. As a mom with no family history of hearing loss in children and no background in audiology or early intervention or anything that would have made this be something that came to my mind as a possibility, it probably took me a little bit longer to come to the realization that I wasn't sure she was hearing. And people would tell me that, well, she's stubborn and strong-willed and she's being defiant and she's ignoring you. And as her mom, I will tell you they were 100% correct. She was all of those things, still is. But she also had some hearing loss at that point. And as her mom, I really had to become an advocate to get her hearing screened. Um, because she'd had ear infections, and the pediatrician minimized my concern about her possible hearing loss. Eventually, I did get her in to be screened, and she was diagnosed with a mild to moderate hearing loss. Um, that did progress. She was profoundly deaf by the time she was around 7 years old. My second daughter was diagnosed at age 1, and she was profoundly deaf by the age of 4. Now, both of these young ladies are thriving and doing very, very well. Um, that would not have been possible without evidence-based hearing screening that was able to identify their loss, and then we were able to get the services that they needed in order to thrive.
You know, Mandy, when I hear your story, I think about all the different ways that could have gone when you started to suspect something. You might not have suspected something, or somebody might have reached a different conclusion, or it may have gone on much longer. It could, we really don't want to wait until there is something observable. We want to get these cases of hearing loss identified before there is evidence of there being a hearing loss. So your story is such a compelling one for all of us to keep in mind. And we really appreciate you sharing that and the fact that those girls are thriving in so many wonderful ways.
Yes, and William, I just want to reiterate, that not every parent would have noticed that. If I hadn't been comparing with my nephew, who was the exact same age, I might have missed it. So it is important that we are doing this without someone suspecting because, like I said, I would have never guessed this.
Right. And you may have had other people trying to put your worries at ease, including healthcare providers who had just said something like we've heard many times, children develop at their own pace, just wait, be patient, you know.
Yes, very
So,
much so.
right. So those children, Mandy's ch children, we want to make sure that, they serve as the goal for all of us to make sure that all children have access to language, full and complete access to language, one way or another, regardless of whether they have a hearing loss, and no matter how significant it may be. And the way to achieve that is to be fully committed to quality, periodic hearing screening and follow up.
Yes, William. And as we mentioned previously, OAE and pure tone audiometry are the recommended methods that we're going to be talking about today. Now, the availability of OAE and pure tone screening really means that it's not appropriate, no longer appropriate to rely solely on subjective methods. These are methods that have been used in the past, such as sound makers and like ringing a bell behind a child's head, or depending solely on a caregiver's perception of a child's hearing. Now, don't get me wrong, observations of a child's response to sound, especially the lack of a response, is helpful. And we need to pay attention to how children do or do not respond to their environment. But these kinds of observations don't constitute a hearing screening. They're just far too crude and unreliable. And frankly, we can do so much better than that with our current available technology.
It's important to note too that although some healthcare providers have in fact incorporated evidence-based hearing screening into well child visits, this really isn't standard practice, especially for children under 4 years of age.
Yeah, it's not. You'll have parents that may report with a lot of certainty that their healthcare provider did perform a hearing screening. But I think we all need to understand this, and I can't really emphasize it enough as an audiologist, that routine examinations of ears, where we physically look in and we look at maybe the middle ear and if there's an infection or something, but those kind of examinations are not hearing screening. So we don't want to mistake that as a hearing screening. It's really precisely because screening isn't happening consistently in that context or that environment that screenings and the screenings and the follow-up that you are all completing are so important.
So the take-home message right here is this: unless a child's health record and medical records include documentation of ear-specific hearing screening results and the screening method within the last 6 to 12 months, we should not assume a hearing screening was completed or that the child passed.
Yeah, exactly. And William, there's another important point to remember too, while we're talking about screening. While OAE and Pure Tone are highly reliable screening methods, there is no perfect screening, methods. So they're not perfect. And that means that there might be some rare conditions that aren't identified through these screenings. So if a parent expresses a concern about a child's hearing or their language development, just kind of like Mandy described for herself, even if the child has received and passed a hearing screening using one of these methods, if those concerns persist, the child should be referred for an evaluation from an audiologist.
Yeah, because think about that. Mandy's daughter, the second child who was identified at 1 year of age. I mean, those children passed their newborn screenings.
Mhm.
So somebody could have made the assumption, good, that's all we need to be concerned about. But it isn't. We need to repeatedly be looking at screenings. So let's talk about these two hearing screening methods that are used during childhood. If you're responsible for children who are under 3 years of age, the one and only recommended method is otoacoustic emissions, or OAE screening, which you see here on the left. And if you're responsible for screening children 3 years of age or older, historically, pure tone audiometry has been considered the recommended method for this age group. This is the headset screening where the child raises a hand or performs another task each time they hear a sound that's presented into one of their earphones. You see this method here on the right.
Yes, and William, I think this is a good time to acknowledge that there's growing recognition that for a variety of reasons, the pure tone method may not always be the most feasible method to use with some children, especially children in the 3 to 5 age range, because our experience and the research has shown that 20 to 25% of the children in that 3 to 5 year age group can't be screened with this methodology because they just aren't developmentally able to follow the directions reliably and participate. So, and pure tone screening can also be difficult to complete with children who have certain developmental delays or differences, or even children that may have a language different than that from the screener. Now, in those instances, when pure tone screening can't be completed, OAE screening is the preferred method then.
So what that means is what? At a minimum, if you're establishing evidence-based practices for 3 to 5 year olds or older, and if you're using pure tone screening, you'll need to be prepared and equipped to do OAEs on the children who can't be screened with pure tone, or if you don't have access to doing OAEs, alternatively, you'd need to be able to have a means for systematically referring all of those children who you couldn't screen to audiologists who could perform the screening. And if you're going to rely on audiologists to cover all of those children, my guess is that you would be pretty challenged in finding audiologists who are available to do all of that screening.
Yeah, and I think maybe even to simplify things more and for efficiency, just like you're talking about, more and more of us audiologists are recommending the use of OAEs uniformly with all children 3 to 5 years of age and older. And we're doing that because it's quicker than pure tone screening, both to learn and to do and to actually implement. And it's far more likely to be a method that'll work across the board with all children in that 3 to 5 and older age group that you'll be screening. And it's equally as effective.
So if you or your school or program are undecided or reconsidering which method to use primarily for children 3 years of age and older, we encourage you to carefully review a document that we have on our website, and I'll show you where to find it in a minute. And this document compares OAE screening and pure tone screening for this population. And so I'll show you in a minute where you can find that.
I want to chime in here for just a minute and say when you're making a decision on methodology, be sure to check your state and local regulations. Some states require pure tone audiometry to be used before OAE is used with these older children, partially because these regulations were developed before the OAE technology was widely available.
Yeah, I do want to just insert, that our professional associations, the American Speech Language Hearing Association, the American Academy of Audiology, all do recognize and support OAE screening for older children as that backup method. So be sure to check those regulations. And boy, we'd sure love you to be advocates for change if those need updated.
So OAE screening, we'll talk about this method a little bit here, is the most appropriate method for identifying young children at risk for permanent hearing loss. First, because it's accurate and it's feasible. It doesn't require a behavioral response from the child, and that allows us to screen children under 3 years of age quite easily. It's quick and easy. Most children can be screened in just a minute or two, sometimes in as little as 30 seconds per ear. It's a flexible tool that can be used in a wide variety of environments, including the classroom, the home, or healthcare setting. Look at this picture right here. Look at where this little guy is being screened at a snack table. They just take a little break to do this. They didn't have to take him out away from all of his friends and walk down the hall. They didn't have to do that. They can go to where he was.
But most importantly, it's effective in identifying children who may have a mild hearing loss or loss in just one ear, as well as those that have a severe bilateral loss or loss in both ears. In addition, it can be helpful in drawing attention to a broader range of hearing health conditions that might need further medical attention. OAE screening can also help to identify children who have a temporary hearing loss as the result of middle ear infections. And while this isn't the primary goal of OAE hearing screening, it's definitely an added benefit of screening with this method.
Take a look for a minute, everybody, at these photos. Look at the diverse settings in which this is happening. These children are being screened using the OAE method. And you'll notice that they, as I said a minute ago, they aren't being pulled out of an environment that they're already in to a foreign or strange environment. They're being screened in everyday educational home and healthcare environments where children are already happily spending their time. And those that are doing their screening are often people they already know. They're children, home visitors, and health specialists. And let me just also interject here that since some of you are, a number of you are school nurses working in school-based screenings, you know, if you have the ability to consider OAE screening, you can imagine how many more children you can screen in a much shorter period of time if you have OAE as an option, because you don't have to, um, for one, just go into a different environment. You can go to where they are.
Yeah, in fact, the screening works best when children are familiar and they're comfortable with the adult doing the screening, and where they can play with the toy, they can be held, or even sleep while the screening's being conducted.
Terry, let's go a step further now. Why don't you walk us through OAE screening and help us understand how the procedure actually works?
Yeah, so first of all, to conduct an OAE screening, we're going to first take a thorough look at the outer part of the ear. We're going to do that to make sure that there's no visible sign of infection or blockage. And then a small probe on which we've placed a disposable cover is then inserted into the ear canal. And that probe delivers a low volume sound stimulus into the ear. Now, a cochlea, or that inner snail-shaped portion of the ear, a cochlea that's functioning normally, it'll respond to this sound by sending the signal to the brain, while at the same time also producing an acoustic emission. This emission is analyzed by your screening unit, and in approximately 30 seconds or so, the result will appear either as a pass or as a refer. Now, every normal, healthy inner ear or cochlea produces an emission that can be recorded in this way.
Okay, so just pause for a minute. You understood that correctly. I'm just going to show this one more time. That that cochlea is actually emitting a sound that is measured by a microphone that is in the probe, and that is how we're able to evaluate the functionality of the cochlea.
Exactly.
So let's take a quick look at what an actual real-time screening can look like with a youngster here. They have the benefit of having two adults in this situation, which is really nice. But this is unedited. So the woman on the right is going to insert the probe, which you see in her hand right now, into his ear. She's going to push a button on a handheld device. And when they celebrate, that's when we know they have either a pass or a refer, indicating that the screening was complete. So let's watch.
Are you ready?
I have a result.
Well, thank you. Okay, you want to put it in this other ear? Put it on the other ear. Let me see, let's try it out. Let's try that one. Okay, you ready? Ready?
There you see the handheld device.
He already did it.
So some of you are probably wondering, okay, how much does this kind of equipment cost? Terry, where are we at right now as far as, I mean, everything is always going up in price. What's the average cost for just a basic OAE device right now?
Yeah, it has gone up. It used to be about $3,800, and it's now about $4,100.
Okay. Yeah.
And that's for a basic piece, a basic OAE piece of equipment, which I like to make the point that's exactly what you need is the basic screener equipment. This equipment will come with other modules or models that are intended for use by audiologists like myself for that are designed for diagnostic purposes. And these are more complicated and more expensive, and you don't need or want the more expensive or complicated models. As screeners and non-audiologists, be careful not to purchase more than you need and get the basic screener models.
Yeah, so if you're seeing prices that are dramatically different from, at least right now, February of 2026, different from about 41 or $4,200, then you need to question whether you're really looking at just a screener type model for lay individuals. Now, in addition to the cost of the equipment itself, there's also those disposable covers that are put on the probe that is then inserted in the ear. And as you might guess, they're going to charge for those things. And I just want to make it really clear, we're not equipment salespeople or anything like that. We're just telling you about what the equipment is. And those covers can range from like $1 to what, $1.50 each. So you'll want to make sure that you purchase enough for those and have probably twice as many of those on hands as you have children to screen, because you'll have to discard some. You might not have the right size you use the first at first. Um, oh,
Yeah.
tell us about the other thing you need to buy with adult probe covers.
Yeah, you will need to plan to purchase some adult size probe covers as well, because during your learning process, as well as on a regular basis, you'll be testing the equipment on your own ears or on another adult just to make sure it's functioning properly before you screen children. It's a good way to check your equipment.
Yeah. When you meet with an equipment distributor or salesperson, they may mention that they will offer you training. Excuse me. And it's important that you understand that that training is rarely sufficient to meet the training needs you actually have.
Yeah, the training offered by the salesperson is intended to acquaint you with all the various functions of the equipment, but they're not going to train you on how to screen young children under a variety of conditions, how to document your results or communicate with parents, or what the follow-up protocol should be when a child doesn't pass. And this has really been a point of confusion for some people, so we just want to make that really clear.
We like to make the analogy that it's like a car salesman at a dealership who may train you on the various functions of your new car and the screen and all the buttons you can push, which is really helpful. You do want that orientation. But that car salesperson is not going to teach you to drive or how to parallel park. It's the same when purchasing hearing screening equipment. You'll need another way to learn the specifics of how to screen. And as we'll point out again, one way is to access an online course that we have on our website, um, and to also rely on local audiologists.
Yeah, if you have a local audiologist, they can then screen alongside you when you're getting started. They can give you helpful pointers. That can be a great way to get, to be sure that you're getting the training that you need. And this is really true whether you need training for OIE screening or if you need training on the other method we're going to talk about now, which is pure tone audiometry.
Before we go on, just know that there are a variety of options in OAE screening equipment. Some of it is better than others of it, partly due to their sensitivity to noise in the environment. So take, some time to evaluate equipment options. See if you can try them out in the environments that you would be screening in, and or get expert input from those that are familiar with OAE screening equipment. Also be aware that I know you've got to be having that question about how are we going to pay for this? I mean, that's a lot of money. One of the things that we have available on our website is a mini grant template, which is a little proposal that we've written that you can download personalized for your school or program to submit to a local charity like a Lions Club or the Sertoma Club and or other grant opportunities that you might have. We've written the narrative for you. You can just take it and submit it. So I'll show you where that is when we take a little tour of our website. Because of course, it's all well and good for us to tell you what best practice is, but you also need money, right, to be able to purchase the right equipment to have in place. Okay, so we've talked about OAE screening, which serves as a backup for those doing screening with 3 to 5 year olds and older, but is the only method that you use for 3 to 5 year olds to be evidence-based. Now let's shift gears and let's talk about the pure tone screening method, which you really need to know is never recommended for children under 3. And as we've mentioned earlier, it has traditionally been acknowledged as the most common recommended method for children 3 to 5 years of age and older. You probably recognize the method either because you already use it or because you've had your own hearing screened this way. In this procedure, musical note-like tones are presented to children through their headphones. And children then provide a behavioral response like raising a hand or dropping a toy into a bucket to tell us that they've heard the tones. Pure tone screening gives us a good idea of the functioning of the entire auditory system all the way to the brain, with the child showing by way of a physical or behavioral indication that they've perceived the sound. It is a relatively affordable method with the screening equipment costing. What is it now, Terry? Is it around 1,000 or?
Yeah, it's actually still in the $800 to $1,000 range. It hasn't gone up too much. So it's remained fairly stable in price.
Okay. And the equipment is durable and portable, enabling us to easily transport it and use it in a variety of locations. And like OAE screening, a wide range of individuals can be trained to perform the pure tone screening method. Terry, tell us how it works.
Yeah, so just like screening with OAEs, to conduct a pure tone screening, we're going to do the same thing. We're going to take a look at the ear, again, to make sure that there's no visible sign of infection or blockage, just like, again, like we do with OAE screening. So if the ear appears normal, now we're going to go and we're going to, the screener, as a screener, you're going to instruct or condition the child how to listen for a tone and provide a response, like raising their hand or placing a toy in a bucket. Now, this step can take a little bit of time so that because we want to be sure that the child is able to reliably complete the screening. Once the screener has observed that the child is reliable, can reliably respond to the sounds that are presented just like you instructed, that's when the actual screening starts. Now, during the screening process, this listen and respond game is repeated. It's going to be repeated at least twice at 3 different pitches on each ear. We're going to note the child's response or their lack of response after each tone is presented. If they respond appropriately and consistently to the range of tones presented each year, the child passes the screening.
So there are 2 especially notable ways pure tone screening differs from OAE screening, and that is that the process requires children not only to be cooperative, but to be full participants in the process, following directions and responding reliably. As we mentioned, that means completing that initial process that we refer to as conditioning or teaching children, and then carefully determining whether or not you, as the screener, are getting reliable responses from them before even attempting to screen.
Yeah, and there's another difference as well between pure tone and OAE screening, and that's that the screening itself is not automated like OAE is. So instead, with pure tone screening, you as the screener have to manually step through the presentations of each tone, and you'll do that multiple times for each ear, recording each response. And then, following a very specific protocol and pass criteria, you as the screener determine whether the ear passed or not. So that's where it becomes elements of subjectivity versus being objective come in. With pure tone screening, there's a considerable more potential for screener error to produce inaccurate results. So that's why there's really a need for thorough training and oversight to make sure all screeners are adhering to the prescribed screening protocol.
Yeah, I just want to interject that even though this procedure is familiar, to most of us, it doesn't mean it's simple. It really does require a lot of adherence to very detailed steps to make sure that we are actually accurately assessing or screening children's hearing. I mean, look at this example. Terry, walk us through all of those manual steps.
Yeah, so here you see a real example of it. These are the actual screening steps that need to be documented for each ear as you screen. So through the training process, you'll learn all of the steps of the conditioning and the screening process, and then all of the environmental conditions that we need to monitor and meet as we complete a child's screening. Based on these results, then you as the screener will determine if each ear passes or not. Again, like I said earlier, the device itself does not produce the result, as is the case with OAE screening.
Each one of these check marks that you see showing up on this form on your screen indicates an individual action that is being taken by the screener and hopefully by the child. Now, I know it sounds like a bias is seeping through here. And I guess maybe there is a bias because we've seen the success of OAE screening when that is an available option. But there's nothing wrong with pure tone screening. It's actually a very good way to screen children in this older age group as long as people have been accurately trained. And as long as those children that can't be screened with this method have another way to be screened. So we mentioned a minute ago that we have a document on our website, and this document that you see on your screen here is a comparison of the two methods and the pros and cons and needs related to implementing them both. So I'll show you on our website here shortly where you'll find that. But if you're in a position to consider OAE screening, to reevaluate where that might be needed, either as that backup method for children that can't be screened with pure tones, or if you have the latitude to consider possibly using OAEs with all children, this document can be a really helpful document to guide a discussion and some decision making around that.
So we've given you an overview of the two methods, and we don't want to say if you find yourself unable to screen a child, it will be when you find yourself unable to screen a given child. It is absolutely critical not to put off screening that child at a later date. Every day matters in this screening process. If you've tried everything, children who are unable to be screened should be referred to an audiologist to complete that screening. In fact, children who are difficult to screen may be the very children we need to identify. So always, always refer a child who is unable to be screened. Regardless of which method you use, you will occasionally have a child who doesn't pass the screening. In order to be evidence-based, your screening process has to include a follow-up protocol for when the children don't pass. Again, I'm going to emphasize our screening efforts are only as good as our ability to systematically follow up on children who don't pass the screening on one or both ears. If we don't do the follow-up, then what's next for this child who didn't pass? It's an important piece of it.
Yeah, it's absolutely, it's not just doing the initial screening, but the follow-up that really matters. So let me give you a quick walkthrough of the protocol and then you can go back and look at it more closely on our website after this webinar. Because this is going to be a quick pass through of what it looks like. The percentage that we're going to give you here are from our data on over 10,000 children in that younger age group, birth to 3 years of age, on whom OAE screening was used. But this protocol pertains to all children, regardless of method, regardless of age. Um, so we expect that children in the 4 to 5 age range or older are going to have better pass rates because they're not as likely to have things like middle ear infections at the same rate that younger children do. So let's take a quick look at the protocol. We're going to screen 100% of the children in a given school or classroom, whatever your group is defined as being. And we expect about 75% will pass on both ears at that first screening. And as a result, will not have the need for any further follow-up. But that leaves about 25% that didn't pass on one or both ears the first time you screened. And they will need to be screened within about 2 weeks.
Now, the interesting thing here at this point is that a good many of the children that didn't pass that first screening, they will pass the second screening. It's really just about 8% of the total number, that 100, say if 8 out of 100 will not pass that second screening. So these children are the ones that will need to be referred to a healthcare provider for a middle ear evaluation.
Now, once a middle ear problem has been identified and resolved and medical clearance has been given, then you'll screen this small number of children a third time.
And here's some more good news. We expect that less than 1% of that total number of children being screened will not pass that third screening. And these are the kids that'll be referred for a pediatric audiological evaluation, so that we'll refer them to a pediatric audiologist to get that evaluation.
So, although a small subset of children will, in fact, need follow-up referral and further screenings after that initial screening, this protocol, which we've had people use in thousands and thousands of early childhood settings and schools, have found that it's a feasible protocol. It helps children get the medical and audiological attention that they need, while it also minimizes unnecessary referrals. Like if you were to refer all children right off the bat when they don't pass the first time, you'd have 25% of your kids being sent to healthcare providers. Well, that would be an undue burden on parents and on the healthcare system.
And another way that this protocol is really helpful is because once you're underway with your screening program, you can use it to check to see if you're getting similar pass and refer percentages. If you find that your individual program's pass and refer percentages are significantly different than we'd anticipate at any point in this protocol, then you might want to seek technical assistance. It's a good kind of quality check.
Yeah, so we have other resources that you can look at that will describe the protocol in depth. It's an important part of the training that at least our online trainings delve into, and you'd want to make sure that however you accomplish your training needs, that this kind of a protocol is clearly understood and adopted universally by all who are engaged in your screening practices. So be sure to look at this. Now, there is one exception to this, step-by-step protocol, and that has to do with when there's a parent concern. Terry, you want to talk about that?
Yeah, this is just right in line with what I mentioned earlier in the webinar that whenever a parent or a caregiver expresses concern about a child's hearing or their language development, that child should be referred for evaluation from a pediatric audiologist, even if they've passed a hearing screening. And this is true because if you recall from what we said earlier, while we have these wonderful screening methods, they're not 100% accurate or perfect. And so, to be on the safe side, whenever there's an explicit concern about hearing or language, go ahead and make a direct referral. And of course, you can and probably ought to still screen the child and send that result along, but make the referral regardless when a concern about hearing or language development has been raised or persists.
Yeah, and Mandy, feel free to chime in here. That includes you as the screener. If even if you see a passing result, but something still is concerning you, make the referral. If a teacher,
Absolutely.
yep, say what you have to say. Mandy, I know you have a strong feeling about
I
that.
do have a strong feeling about it because it's just like we've said over and over again. One day, one referral, you can make a difference in the life of this child and this family. And so, even if it is you having the concern or the parent, teacher, whoever, please make that referral for the sake of that child.
Yeah. So let's take a quick look at our website. We've referred to a number of resources that are available on kidshearing.org, which you see on your screen right there. Many free resources for you to download, adapt. We've got all sorts of things. So let's take a quick little look at what we've got there. This is the landing page for kidshearing.org. That first group of resources where you see the pink arrow have to do with planning resources, big picture resources, information that you can give out to your colleagues, to parents, um, talking about the overall need and approach to early identification of hearing loss. Under that, you'll see a bullet that says find an audiologist. That's where you'll find several different directories for locating pediatric audiologists in your state and possibly in your local community. If you're seeking equipment information, that's that bullet there that says screening equipment. That's where you'll find some equipment information. What are the current different brands? What are the criteria to use when selecting equipment? And also where you'll find that grant proposal template for getting some requests out to help purchase equipment or supplies. In the next category, that's where you'll find access to our online training opportunities, either for OAE or for Pure Tone. So if training is a need, you you should give a look at that. The advantages that we can point out to the online training is that one, you can do it whenever you want to. If you have new people that are coming in, they can do it right away. You can do it as a group, you can do it individually. Ideally, having an audiologist participate in some of the practice exercises once you've completed the online portions of the tutorials is really a great idea because then you have the benefit of their expertise to be with you, alongside you, giving their helpful cues. So the best possible scenario is to use a standardized curriculum so that everybody's hearing and getting the same information, but then you also have the benefit of an expert right in your own presence. The next group of resources are practical everyday resources for screening and follow-up. Checklists for what you need to set up a screening day with a group of children. There's a review of the protocol guide and forms that correspond with our recommended protocols so that you will document every single possible outcome. And then a group of of resources to help you share those results. There are letters for parents in English and in Spanish. There's a script there of what to say to parents at various points in the screening or follow-up process, as well as letters that you can send along with a referral to a healthcare provider that not only explains the result of the given child you're referring, but explains very briefly what your screening approach is and what you're needing from them, and the fact that you may be needing a referral from them if the child doesn't pass once you get medical clearance from the middle ear referral. And then in that last group, there are follow-up resources. There's a tracking tool. So if you have a group of, let's say, 100 children you're screening, this tracking tool helps you know at any given moment how many of those children have passed, who hasn't, and at what point in the follow-up protocol are they? What is the next step? Um, and so that can be a really helpful tool in making sure that no children slip through the cracks. And then there's a variety of other resources under that. So that's kidshearing.org. So lots of other resources there that we invite you to spend some time looking at. So we're going to open up for some questions now in the chat. And, you know, I really want to direct your thoughts and mind back to what we saw with these children and think about what the outcomes and the life-changing outcomes this represents for the children who were identified as the result of somebody's screening. Now, for those of you who are screening slightly older children, you probably won't be identifying children who are already profoundly deaf. If they're older already, that probably would have occurred, hopefully, sometime earlier on. But you very much can identify children who have a mild or moderate hearing loss, or like in the case of Mandy's children, who had not only a mild loss, but one that was progressive to becoming severe or to profound. So, Mandy, as a public health expert and a parent of children who are deaf or hard of hearing, we know the importance of hearing screening is like very real for you.
Yes, it really is. For those of you on this webinar, you may not have ever thought about it quite like this, but monitoring the status of children's hearing is central to quality early childhood programs. It's central to the educational process across all of the school years and to all of us who are committed to children's success. So, when children with hearing loss are identified and connected with the intervention resources that they need, they can thrive, just like the children that you watched the videos of earlier that are pictured on the screen now, and just like my daughters. But that does depend on someone somewhere along the way, someone like you, identifying their hearing loss. And you can be that important person in that child and family's life. When you are that person, you can have the satisfaction of knowing that you were a part of an outcome that literally changed their life forever from an educational standpoint, a social and emotional standpoint, just every aspect, you can make a difference in this child's life.
All right. So thank you, Mandy, for always bringing that very important point forward. So we have some questions coming in, and the first question, Terry, is about pure tone screening. What are your thoughts on doing pure tone screening for 500 hertz? And in the Wisconsin School Nurse booklet, it recommends 500,000, 2,000, and 4,000 hertz. And we have found that getting the 500 hertz is pretty difficult sometimes.
Yeah, and I think there's also another comment about 500 hertz as well. So the recommended frequencies are 1,000, 2,000, and 4,000. And those are recommendations made by the national associations. The reason 500 hertz usually is not included is because of background noise, what we kind of refer to as the noise floor of the environment or the room. And low frequency noise tends to overpower. And so when we were screening in that lower frequency range, we often get noise interference.
So the next question is about OAE screening. Is the OAE screening result affected by a middle ear infection or effusion? So maybe, Terry, I can go back to that slide if I'm lucky. And
Yeah.
you can talk about that a little bit here.
Yeah, so anything like a wax blockage or middle ear infusion can stop our ability to measure the emission that is coming back out. And as we've talked, that's actually kind of one of the it's not the primary purpose, but one of the side benefits of screening because we wait 2 weeks, we rescreen. Do you remember that approximately 25% that referred on the first screen will now be about 8? And usually that is due to because these middle ear conditions have cleared up.
Yeah, but one of the risks related to this is that sometimes we get into a confusion around this that okay, we get focused on, treating middle ear effusion and ear infection, for example, and then once the child is cleared up, we think, okay, we're done. But really, we're not because we've never evaluated the inner ear. So even though there's a side benefit, remember that the target condition is this inner ear. And so we've got to make sure that our focus always comes back to that.
Yeah,
With
thank you, William.
with regards to OAE, here's another question. Given the nature of this screening, it appears that it can only identify hearing conditions related only to the ear and cannot identify issues resulting in communication with the temporal lobe. How does this affect how accurate OAE screening results are at identifying hearing conditions?
Yeah, and so what we're talking about is, are there problems that go beyond the inner ear, so those neural pathways and to the auditory centers of the brain? I'm going to start with a very end question, which is really looks at how often does that occur? What percentage of child hearing loss is related to conditions of the brain rather than structurally in the ear? It's it's very low incidence. So for comparison, remember we talked about 3 per thousand in newborn screening for hearing loss? Well, these types of things are so much more rare. There's 1 to 3 per 10,000 births. And so it's very rare, and there is no good screening instrument or test for these disorders. Both OAE and pure tone might miss those. But the bottom line is we do not want to not screen just because the chance of missing a very rare disorder.
Yeah, and that's like the big dilemma, I guess, or I don't know if it's even a dilemma of public health screenings, which is what we're really talking about here. We screen for the most common, not for the most rare. And that's true across all aspects of health screenings. So this is no different. Yes, you're right. There could be other things that could be going on. And that's why if there is a concern, even if the child passes a screening,
Yeah.
we want to make sure there's a thorough audiological evaluation done. So
Yeah,
that,
exactly. I hope we made that point a couple times that if those concerns persist, even with a passing result, that we refer.
yeah. So, Terry, another question or two here. Can you describe the difference in terms of usefulness of completing OAE screening versus tympanometry screening? And is tympanometry ever recommended in screening young children?
Yeah, thank you for that question. I'm smiling because that was part of our early work with William and I because we had actually included tympanometry in our pilot project. And we found really no difference. And so that's why tympanometry is actually not part of this protocol. Um, Tympanometry, for those of you that are on that may not know, is a test of middle ear function. And so it mechanically tries to move the eardrum. And if there's fluid back there, we can't measure that movement. And then we think that there may be a fluid filled middle ear. Both resulted in the same thing. Within 2 weeks, things cleared up. A majority of the kids that had referred passed. And then those ones that went in for middle ear evaluation. So we found we didn't save time, efficiency, or any of those things using tympanometry, and that we found that those referring on OAE were the same kids that would have referred on tympanometry.
So we're getting close to the bottom of the hour, and if you all have to split, note in the chat field a link to an evaluation for us, which will also produce a certificate of attendance for your time on today's webinar. But we're going to try to hang in here for another couple of minutes to answer a few more questions. And be sure to note that you can find this webinar again along with lots of our resources on kidshearing.org. So here's the question. Is there a place for the use of OAEs in school settings for states that do not have updated legislation? In other words, where pure tone is still on the books. And the recommendation that we can make, and Terry helped me with this, is that doing pure tone screening with 3 to 5 year olds, if that's the regulation, then by all means, you need to try that. But know that if you can't complete those screenings with pure tone method, the American Academy of Audiology and the American the AAP, right? No, ASHA, the
Yeah.
American Speech Language Hearing Association, both recommend and guide that OAE should be the second step screening for when children of any age cannot be screened using the pure tone method. Anything more to add to that?
No, other than it is just universally accepted as that it should be used in those cases.
Yeah.
It's really a standard of care, and those things need to be updated.
There's a question here about the training access. It says that you need to have access to equipment before completing the training. Yes, I mean that would make sense, right? That if before you do training, the training that is offered on our website is all very hands-on training. So of course you need to have either the Pure Tone or the OAE or whichever training you're doing. Um, and there's information also um, on selecting equipment on our website. So you'd want to look there for information that would help guide the purchasing process. Once again, no, we are not selling equipment. That is not who we are, but we want to help you use the equipment that you purchase from other manufacturers or distributors. Um, well, I think we're past the bottom of the hour. We didn't get to everybody's questions, but you're welcome to text message us through our website if there are other questions you'd like us to address. Remember that today's webinar was recorded, and so you can review it or share it with others, um, along with checking out all of the other resources that we have available there. And be sure to also complete the evaluation and get your certificate of attendance for today, which is a link that's been provided in and it's also here on your screen if you don't see that in the chat. Mandy, thank you for being with us, wearing both hats as a public health expert as well as a parent expert of children who are deaf or hard of hearing, being such a good reminder of the reality that, you know, we will screen a lot of children who pass. And when we screen children who don't, and they are ultimately identified with a hearing loss, we've participated in changing that child's life forever. So that's something to really hang our hats on. It's also very important to note that when you screen all of those children that pass, and you've done it correctly, you've helped rule out screening so that, or hearing, so that if that child has other challenges, you can confidently know that hearing is not the factor. So both of those are give us some comfort in knowing the value of our work. And Terry, thank you for your time and expertise yet again. Yes?
Yep, absolutely. Thank you.
Yep. All right. To our technical support people in the background, thank you as always. And to everybody there, thank you for all the work that you do on behalf of children and families. Have a good rest of the day.
Thank you.